Welcome to Fits on the Go at ACC 26. I'm Kanu Bansal, a cardiology fellow at St. Vincent, Massachusetts, and I'm joined by Professor Wayne Batchelor, interventional cardiologist at Innova Fairfax, Virginia. Thank you, Dr. Batchelor, and thank you for sharing the late breaker trial that you're presenting, the ALERT trial. Could you tell us more about this?
Yeah, first of all, thanks for having me. It's a pleasure to speak to you this morning, Canoe, and I'm really excited to discuss the results of the ALERT trial. So, the ALERT trial is addressing a pervasive issue that we have across the country and indeed the world, and that's the continued undertreatment of both aortic stenosis and mitral regurgitation. There are a number of reasons why undertreatment occurs, but some of it is just because of a lack of referral and diagnosis and treatment. So we just took a simple question, whether or not finding patients within electronic health records through simple cardiac intelligence software, if that could provide an incremental uptick in the number of patients appropriately referred and treated for these types of valvular heart conditions. So we did a randomized, cluster randomized trial of patients who had significant aortic stenosis or significant mitral regurgitation. By that I mean patients who had at least one of the classic criteria for severe aortic stenosis on echo, and had to have at least a mean gradient of 15, but any other of the criteria, valve gradient, a mean gradient of 40, or velocity over 4 meters per second, and valve area of less than 1. For the mitral regurgitation patients, they had to have what we traditionally call 3 to 4 plus mitral regurgitation, moderate to severe or severe, qualitatively. And once those patients were identified, we excluded patients who were already referred to the multidisciplinary heart team or already planned for valve intervention. And then we randomized the remainder of those clinicians who had not yet referred to receive a simple electronic notification in the form of a prompt that went to the inbox in the electronic health record of that clinician. So clinicians were randomized to receive alert versus no alert. And then we followed what happened in the next 90 days, recognizing that the performance metric for severe AS and MR is to have a valve intervention and multidisciplinary heart team assessment as a guideline-directed recommendation. So we carried this out, and we found out that the alerts did make a difference. As a clinician decision aid, it did prompt physicians to refer more to the multidisciplinary heart team, and ultimately that led to a statistically significant increase in valve intervention, multidisciplinary heart team referral, and the primary endpoint was actually a composite of the two based on a hierarchical win ratio, which turned out to be 1.27 on the win ratio in favor of the alert versus no alert.
That is great news for our patients. Do you think what exactly were physicians ascribing to when they were receiving the alerts, and what did the alert notification actually include? What information did it have?
Yeah, it's a very good question. The alert notification verbiage was at the discretion of the site. So they constructed their own alert. There were 5 sites, 35 hospitals total, and each of the sites was responsible for creating its own alert. But generally speaking, the alerts had something along the lines of, your patient, Mr. or Mrs. X, was identified as having potentially significant aortic stenosis or mitral regurgitation. According to the AHA-ACC guidelines, this may be an appropriate patient to consider for referral to the multidisciplinary heart team. Here's how you can make that referral if you want. If you have any questions, call us, that kind of thing. So it wasn't an automatic referral. It was more of just a nudge to use as a sort of clinical decision-making aid to help some referring physicians to know when to refer. Remember that these are health systems, so we're looking at this at scale across health systems. A lot of cardiologists know how to sort of refer it and when to refer, but remember, a lot of physicians or clinicians who order echoes are not cardiologists. Many are internists or primary care physicians and other docs. And so when you look at this at scale, it actually made a significant difference. The likelihood of referral to the multidisciplinary heart team was up by, relative increase of over 20%, and it was a 40% increase in actual valve interventions, which is, significant. So I think that this is a valuable, simple aid that can be deployed across health systems and run in the background on top of an EHR potentially to help identify patients who thus far have not been treated.
And this also looks like a novel application of an AI software to gather all the information and glean it into a simple prompt. Do you think we could see something similar in future trials, especially in this space?
Yeah, I think what remains to be seen is whether or not this translates into improved long-term outcomes. Those will be interesting studies to carry out. This was a short-term study, obviously, more of an implementation science type of look at this. But I think that we are at the point where it almost is becoming to the point where it almost doesn't make sense to not use the simple things that we have at our disposal. Now, of course, there are resources and cost and other things that one has to consider. But if you have access to some of these tools, they can be deployed at scale in health systems and translate into meaningful differences in referral patterns and physician behavior that we would expect to help patients do better and have better outcomes.
And something that you were interested in was also underrepresented populations such as females and people of
Yes.
race. So what did you find in that? What did you find
Yeah.
in the trial?
Great question. I have a particular interest in healthcare disparities, and it's something that's really been near and dear to my heart for years. So I was really curious about this trial in terms of could it close that disparity gap? One of the things that we noticed that the effect of the alert was very similar across all of our pre-specified subgroups: older patients, younger patients, female versus male sex, different races and ethnicities, patients who are inpatient versus outpatient, different sites, rural versus urban, and social deprivation index. The point estimate for the improvement in multidisciplinary heart team referral and valve intervention was comparable or very similar across those different groups. In fact, for blacks versus non-Hispanic white patients, the effect of the alert was very similar, which was helpful. It didn't completely close that gap. There was still a gap, but at least it showed that the effectiveness was comparable across subgroups, sort of having a sort of an agnostic look at this, which is not as prone to treatment or referral bias.
This is a very pragmatic and scalable intervention, and it's definitely very low cost compared to some of the other interventions that we do. What are some of the other barriers that you may see if you want to apply this to our hospital setups tomorrow? Because you studied it at large hospital centers, for example.
Yeah. Well, several things to consider. Number one, it's only as effective as the rest of the care pathway that that accompanies it. So it has to be. It can't be sort of in replace of. It's in addition to good, high quality care and clinician awareness. Alert fatigue is something we always get concerned about, but we looked at 2016 echoes and a little over 700 providers, and the average alert was about 2.6 per provider. So in the alert arms, and that's not that bad over a 13-month period. So we're not overly burdening physicians with a lot of alert fatigue, but that's a concern. And then other things relate to just the ability to deploy this. On the front end, there's a little bit of a build. There has to be an interface build between this, in this case, Tempus AI, cardiac intelligence software, and the EHR. So that's a little upfront effort, and that requires, obviously IT investment and also administrative acceptance. A lot of administrators don't necessarily like additional things added to the EHR. So, but in these 5 health systems, they found it very, very useful.
And one last thing, you and I care about valve disease. How does this trial change our message on identifying severe valve disease on an echo and changing our care pathways?
Yeah, a couple of observations. Even with alert, the overall treatment rate for multidisciplinary heart team referral and valve intervention was still only like 24%. So now we don't know what the real number should have been necessarily, but I suspect we're still under treating. And if you look at this across the United States, it's estimated that only about 50% of patients who actually have a class 1 or class 2 indication for valve intervention actually get it. So I think it's not it's not a panacea, and it doesn't get us to where we need to be, but it's a good incremental step forward. That's important. And then the other thing is, I think it's just also just getting accompanying it with the education piece, getting out there and making sure that all of our, not only cardiologists but referring physicians have a sense for the current guidelines for whom to consider for referral. There's still some opportunity there that I think is an unmet need. So that's education and cascading of important information to the right people.
Thank you. Thank you, Dr. Batchelor, and thank you for your time. Thank you for Fits on the Go. And please don't forget to check out our YouTube channel for more videos at Fits on the Go. Thank you.